Hello, and welcome to the very first episode of the Therapeutics Chronicles. I'm your host, Momin Wali, and I'm thrilled to have you here as we launch this journey of simplifying medication use and empowering healthcare professionals. Whether you are a student looking to boost your understanding, an early career professional strengthening your foundation, or even an educator refining your practice, this podcast is for you. Our mission is simple yet impactful: to simplify and streamline the understanding of medications, clinical tools, and practical insights. To kick things off, we are going to dive into one of the most prescribed medications worldwide, Metformin. It is the backbone of type 2 diabetes management, and yet common errors in its use still crop up. So today, we are breaking down what makes Metformin such a cornerstone drug, how to use it effectively, and how to avoid the pitfalls. Metformin belongs to the biguanide class, and its mechanism of action is straightforward yet powerful. It reduces hepatic glucose production, increases insulin sensitivity in peripheral tissues, and decreases intestinal glucose absorption. These combined effects make it an excellent first-line option for type 2 diabetes management. Why is it so effective? Because it tackles the core problem of insulin resistance rather than just treating the symptoms. Plus, it does not cause hypoglycemia when used on its own, which is a significant advantage over some other glucose-lowering drugs. This is particularly important for patients who may already struggle with the fear of low blood sugar, a common barrier to adherence with other treatments. Pharmacokinetics-wise, metformin is absorbed in the small intestine, with bioavailability around 50 to 60%. It is not metabolized by the liver but is excreted unchanged by the kidneys. This renal excretion is why renal function monitoring is so crucial. The half-life of metformin is around 6 hours, but its effect on glucose levels lasts much longer due to its action on hepatic glucose production. This extended effect contributes to its popularity as a reliable daily medication. Importantly, metformin does not undergo significant metabolism, which minimizes drug-drug interactions and makes it a safer option in polypharmacy. So, who should take it? Metformin is primarily indicated for type 2 diabetes but also sees off-label use in conditions like polycystic ovary syndrome, PCOS, and prediabetes. In PCOS, its insulin sensitizing effects can help improve ovulation and manage hyperandrogenism. For prediabetes, metformin can delay progression to type 2 diabetes, especially in younger patients with higher body mass index or women with a history of gestational diabetes. In some cases, clinicians may even consider metformin for weight management due to its ability to modulate appetite and improve insulin resistance, though this is not a primary indication. The dose typically starts at 500 mg once or twice daily with meals to reduce gastrointestinal side effects. Titrating the dose slowly up to a maximum of 200 to 2500 mg daily is key to improving tolerability while achieving glycemic targets. But let's talk side effects. The most common are gastrointestinal, nausea, diarrhea, and abdominal discomfort. These are usually transient and can be minimized by taking the medication with food and using an extended release formulation. Educating patients about this upfront can help set expectations and improve adherence. Rarely, lactic acidosis can occur, particularly in patients with significant renal impairment or other risk factors like heart failure or liver disease. This risk, while low, is serious, making regular monitoring of renal function non-negotiable. Always assess eGFR before starting metformin and periodically thereafter, especially in older adults or those with chronic kidney disease. A sudden decline in kidney function or acute illness should prompt re-evaluation of the therapy. Now, Let's address drug interactions. Metformin has relatively few interactions compared to other diabetes medications, but there are some to watch out for. Iodinated contrast agents can increase the risk of lactic acidosis, so metformin should be temporarily discontinued before and after imaging studies if renal function is at risk. Cimetidine, a less commonly used drug, can increase metformin levels by competing for renal tubular secretion. And do not forget alcohol. Excessive use can elevate the risk of lactic acidosis, so it is crucial to counsel patients about moderation. For patients on multiple medications, it is good practice to review their regimen periodically, particularly if they are started on new drugs that could affect kidney function. Let's move on to practical considerations. A common mistake is starting metformin at a high dose right away, which often leads to gastrointestinal intolerance and poor adherence. Instead, start low and go slow. Another pitfall: ignoring renal function. Prescribing metformin in patients with severely reduced renal function can lead to serious complications. Remember, the current guidelines recommend avoiding metformin if the eGFR is below 30 ml per minute, and using caution when it is between 30 to 45 ml per minute. For those patients in this range, a reduced dose and close monitoring can help balance benefits and risks. Counseling patients about the importance of regular kidney function tests is an excellent way to promote shared decision making and adherence. Let's walk through a few case scenarios. Case 1. A 55-year-old female newly diagnosed with type 2 diabetes is started on metformin 500 mg twice daily. She returns complaining of diarrhea. What is the solution? First, check adherence to meal timing. If she's taking it on an empty stomach, switching to taking it with food may resolve the issue. If symptoms persist, switching to an extended release formulation can help. Case 2. A 65-year-old male with an eGFR of 30 ml per minute is started on metformin. What is the problem here? This is a gray area, so you should use a lower dose. Monitor renal function closely and consider alternatives if kidney function deteriorates. Case 3. A 45-year-old patient on metformin is scheduled for CT scan with contrast. Stop metformin temporarily and re-evaluate renal function 48 hours after the scan before restarting it. These are real-world scenarios where small adjustments can make a big difference. Now, let's dive into the broader benefits of metformin beyond glucose control. Did you know that metformin has cardiovascular benefits? Studies have shown that it can reduce the risk of myocardial infarctions and strokes in patients with type 2 diabetes. There is even emerging evidence suggesting metformin may have anti-aging properties and a potential role in cancer prevention. Metformin's affordability and extensive safety profile further make it a valuable option in global healthcare, particularly in resource-limited settings. So let's wrap up with some clinical gems. First, metformin's long-term benefits extend beyond glucose control. It's been shown to reduce cardiovascular events and even has some evidence suggesting a role in cancer prevention. Second, for patients struggling with gastrointestinal side effects, reassure them that these are often temporary and explore extended release formulations. Lastly, always emphasize the importance of lifestyle modifications alongside metformin. Diet and exercise amplify its effects and can help some patients achieve glycemic control with lower doses. Encourage patients to see metformin as part of a comprehensive plan rather than a standalone solution. And a one bonus step: when discontinuing metformin temporarily for imaging studies or acute illness, make a clear plan for follow-up to avoid prolonged gaps in therapy. Alright, rapid Q&A time. What is metformin's primary mechanism of action? Reducing hepatic glucose production. Can it cause hypoglycemia on its own? No, it does not. What is a key contraindication? eGFR below 30 ml per minute. And What is the most common side effect? Gastrointestinal upset. Bonus question. How can side effects be minimized? By starting with a low dose and taking it with food. And that's a wrap for the very first episode of the Therapeutics Chronicles. I hope you found this discussion on metformin both practical and insightful. Do not forget to subscribe, share this episode with your colleagues, and send your feedback to the Therapeutics Chronicles at gmail.com. You can also connect with me personally on LinkedIn at Momin Wali. Stay curious, keep learning, and let's continue making a difference in patient care. Until next time, this is Momin Wali signing off. Take care.